Hey guys, welcome back to one more episode of Gross Pathology Discussion, and in this module we are going to talk about 5 more cases, right? All these might come in an exam. We are going to follow the same thing what we saw in the previous lecture. The same way I'm going to show you an image. This might not be the exact image which will come in your exam, but definitely something similar to it, right? And also I have the 5-6 most common Viva points which might steer around the discussion of the same exam session, right? If you're ready for the game, as usual, put on a big smile and let's start discussing about more gross spotters. Fine. The first thing is CA colon. I'm sure you must have seen specimens of CA colon in your hospital, be it jar mounted or be it a fresh specimen, right? The first and the foremost thing, I have always given you a template. First, please let the examiner know that you understand this is colon. How will you know that? The first thing, as usual, you have to flip the thing, and if there's a whiteboard here, it's difficult for me to identify the back part. Otherwise, if it's just mounted with threads, you can easily look at the back part and identify them, right? If you go to the back part of the colon, right, that is the serosal surface, you might see the tiny tinea coli or something of mesentery which can help you to identify this is a large intestine, or the hostrations are wide enough for me to help to identify it's a large intestine, right? It's enough if you say it's a large intestine. You need not be very specific in saying it's an ascending colon or descending colon, right? So how will I start it? It's a specimen of a colectomy as per the shape, size of the lumen, and also when I look back I can see the tinea coli and the attachments, right? Based on that I know that it's a cut open specimen of a colectomy, right? So from in the inner surface, in the mucosa, what I am seeing here, right? The first and the foremost thing, like I said, the teacher should be able to imagine what you're talking about even if the teacher is not seeing the specimen, right? So first and foremost thing, there is a cut open specimen in the mucosal surface. What I'm seeing is an ulceroproliferative growth, which is, let's say, 5 centimeter from the proximal margin and maybe 6-7 centimeter from the distal margin. These are very important, right? Not just for imagination perspective, this will make sure that surgery done is appropriate, adequate, right? So the distance from the margin should be definitely decent enough, right? So if you have a jar mounted specimen, if you're not able to exactly measure, keep a rough idea that one phalanx, this is around 2.5 centimeter, right? Just based on that, say approximately 5 centimeter, approximately 8 centimeter, right? And the lesion per se is measuring so and so centimeter in 2 dimensions, because the third dimension might be difficult if it's a jar mounted specimen, right? So I have an ulceroproliferative growth of, let's say, 4 to 5 centimeter, and which is 5 centimeter from the proximal margin and 6 centimeter from the distal margin, right? And this ulceroproliferative growth shows a little bit of area of necrosis, right? So this will make sure that I am dealing about a carcinoma colon. And the most important thing, the rest of the mucosa appears normal. But if there's a tiny polyp here, couple of them, mention that, because that will change the diagnosis into whether it's a polyposis converting to an adenocarcinoma or is a per se an adenocarcinoma. This is very, very important for you to know that, right? So based on the above input, I'm thinking that this is most likely a carcinoma colon. That's all. That's how you're going to end the discussion with, right? So once you say it's carcinoma colon, if you take good enough time to explain and tell, that itself will make sure the examiner, okay, this student knows what he or she is talking about. That is the most important. The first impression is the most important thing in a Viva, not the answer. Like I said in the first video itself, I'm not looking for an answer. I'm looking for an approach, that's all. Because biopsy is ultimately the diagnostic clue here, right? Now, how do you identify it is? Okay, so now identifies, how do you know it's a right side or a left side colonic carcinoma? Grossly. See, right side colon and left side colon, theoretically there's a different way of them presenting, right? One will have a proliferative mass, one will have an infiltrative mass, right? In colorectal tumors, the right side tumors are generally bulky and polypoidal, very, very important. And the left side tumors are generally infiltrative, annular constricting, right? That's why you must have definitely read the term, this, let's assume this colon, whereas an infiltrating mass in the left side of the colon, when you do a barium enema or a barium meal, you'll have a apple core lesion. That's very, very important. A napkin ring lesion because of the constriction. Because of this right and left side differences, the left side colon tumors generally present with obstruction because of stricture. Right side, they are ulceroproliferative mass. It's very huge for me to obstruct. They might present with the old tiny amounts of blood loss, classical iron deficiency anemia, right? Again, based on the gross appearances, right? Next, what's the most common histological type? See, this is something which is very, very simple and I want you to know without fail, right? You have to know the most common subtype of cancers for all the organ systems. Entire GAT only one guy is going to be adenocarcinoma. Colorectal adenocarcinoma is by default the most common. What other things can happen? Be sure that almost everything will have epithelial and mesenchyme. Don't just jump and say, I can have neuron degrade. No. They asked you what are the other tumors can happen. Classify them. Tell them, convey them, I have a clear-cut idea of how the disease is going to present to the entire organ system, not only one disease. I can divide the tumors of the colon into epithelial and mesenchymal. In the epithelial, I can divide them into benign and malignant. In the benign, I have adenomas. Tubular adenoma, villus adenoma, pugiger, juvenile polyp, the basic things. And I have colorectal adenocarcinoma, which can be syndromic, which can be sporadic. You are taking the conversation. When I say this, the next question will be, what are the symptoms will be associated, right? You know that answer, so take it them there. And I can also have mesenchymal tumors. You can have GIST, you can have leiomyoma, you can have any vascular tumors whatsoever, right? Perfect. Then, if they ask you an adenoma carcinoma sequence, if I am the examiner, I am definitely interested in doing two important things. What is the adenoma carcinoma sequence of the classical adenoma that is FAP related? I don't know the entire sequence. I at least wanted to know something about it. And also I'll definitely ask a question on Lynch syndrome or HNPCC. Because these are the two dominant things, right? So by default, it's the APC loss. Along with the APC, I can have beta-catenin gain of function mutation. Then I have KRAS. This is one of the important guys which converts a normal mucosa into a polypoidal extension or a tumor per se. Then I can have P53. And the last guy after becoming carcinoma is their telomerase. Telomerase activation is the terminal one, which kind of makes them become malignant and metastasize throughout the body, right? The same thing goes for Lynch syndrome. So that's the next question here. What do you mean by Lynch syndrome? Lynch syndrome or hereditary non-polyposis colon cancer. Okay. The first and the foremost thing is, non-polyposis does not mean that this patient will not have multiple polyps. They also will have multiple polyps without fail. Right? They are not 100 polyps like FAP, that's all, right? These two are almost same. Lynch syndrome is HNPCC, where the problem is in methyl mismatch repair defect. What's a mismatch repair? It's a mechanism of DNA repair, that's all, right? So you have MSH, MLH, these are two things which I want you to know. MSH gene, MLH gene are getting mutated, which develops mostly in the right-sided colonic cancer. This also is something which I will be expecting you to tell me. Right-side colonic tumors are more common in Lynch syndrome. So it's a syndrome, right? So what other tumors can happen will be obviously the leading question, right? In Lynch syndrome, there's a germline mutation, which means you get them from your parents. Along with colonic cancer, you'll also have endometrial cancer, you can have skin tumors, you can have renal pelvis tumors. These are the association with Lynch syndrome or HNPCC without fail, right? Okay. And the last but not least is, tell me something about the major prognostic factors. This by default will be a question which will be asked for every cancer. If you have one question asked for multiple disease, which means I can template it. Please don't read each and every cancer, okay, prognostic feature, prognostic feature. There is a template which can never go wrong. I told this in the previous class, discussion as well. One is TNM. TNM by default is one of the most important determining factor for the prognosis of the patient, the stage of the tumor. Then obviously, the grading of the tumor. Right, grading is a microscopic finding. A well-differentiated adenocarcinoma is definitely good for me compared to a poorly differentiated adenocarcinoma. Without fail, right? By default, these are important things for me. Lymph node involvement, invasion, and distant metastasis. That's my TNM. At the same time, lymphovascular perineal invasion, right? Definitely. If it's going to go into the lymphovascular space, by default, I'm saying that it has gone into the lymph node. Maybe I have not identified it yet, that's all, right? So definitely lymphovascular invasion in the microscopy, perineal invasion is definitely indicative of a higher grade of the tumor, higher staging of the tumor, right? Molecular features also provide good prognostic information, right? This, I wanted to put a star here. I don't want you to tell in every cancer, molecular genetics helps. Answer, yes, it helps. If they ask, let's tell. Don't put yourself out there, that's all. Because you might not know the molecular genetics prognostic feature for every cancer. If you know, like for breast cancer, I know, tell there. Right? Otherwise, don't tell. But here, KRAS is something which is a bad mutation. KRAS will definitely make the tumor chemo-resistant. That's important, which I want you to remember. Basic at least, which I want you to remember with respect to colonic tumors by default, right? So that's about the simple explanation of a sample of colonic carcinoma, which can definitely come in an exam. Just have a look at that, right? Next guy. A very simple sample, a very simple specimen, but the discussion is going to kill you. Trust me, if I am the student, I'll be more worried in having tuberculosis in front of me than having a very complex cancer which I don't know. Because the examiner expects you to know everything about TB. Even if you don't answer tiny things, they're like, this guy or girl does not know about TB. That's a basic requirement, right? Colonic cancer, okay. If I miss molecular genetics, is okay. But TB, if I miss even something, they may get offended, right? So if it's tuberculosis, if it's an easy sample, please make sure that you are well prepared to talk for at least 5-6 minutes, right? Now, this sample, how will I describe them? So first and the foremost question, gesture is important, right? You turn, look at it, how you're going to talk about it. So you can say that this is a jar-mounted specimen of a lymphadenectomy or a post-mortem removal of a cluster of lymph nodes. How do I say it's lymph node? I can see multiple well-defined capsulated structures in a background of fatty parenchyma or a soft tissue parenchyma. That's most likely a lymph node. That's what I think of, right? And the second thing which I want you to tell is these lymph nodes, quite a few of them are attached to one another. That is what matted lymph nodes mean, right? That's very important. Even if you see here, they're not single lymph nodes. I do see single lymph nodes. At the same time, look at them. They are, this is one separate guy, this is one separate guy, this is one separate guy, right? This is one separate guy, this is one separate guy. They are attached. They are matted, right? That's very important for you to tell, yeah, I have matting of lymph nodes seen. Not just that, on the cut surface of the lymph nodes, predominant of them are grayish in color. Gray tan color is the normal curve of lymph node, right? But if you have a pencil or a pen while explaining to the examiner, use them. Right? It's a prop. This is a specimen. You can point out this place. That makes them much more interesting and much more interactive, right? Most of the lymph nodes are gray tan, but in few places, like here, I can see a whitish area which is partly effacing the lymph node. See, this is normal, this is normal, this is normal. But I do see lots of lymph nodes have little bit of whitish area, little bit of whitish area. So my provisional diagnosis in this patient is because of the matted nature of the lymph nodes and multiple lymphadenopathy and the whitish area, I think of a caseous necrosis or a necrotizing lymphadenopathy. My most likely diagnosis is tuberculous lymphadenopathy, right? That's how you have to present. Don't jump and say, it's TB lymph node. Talk for 1 minute. It's completely fine. Talk for 1 minute and then go and tell the answer, right? Okay, that's how you describe. The lymph nodes are enlarged, matted, yellow-white area. These three keywords are something which is important for me to see in the question. That's very important. Don't miss them, right? Why is there matted? Matted lymph nodes are nothing but these lymph nodes are joining each other. It's a very classical feature of TB lymphadenitis for the reason that TB is one disease, an inflammatory disease, where the inflammation can go pericapsular. That is very important. Pericapsular inflammation, let's say two lymph nodes are there, both the places pericapsular inflammation. That kind of fixes them. That's we call them a periadenitis. Periadenitis, perinodal inflammation, pericapsular inflammation. If you see any one of these words, that's important for me. Because of the periadenitis, which is classical for tuberculosis, there's a chance that one lymph node can go and adhere to other and can become a mass. That's matted lymph nodes. It's very classical for tuberculosis, right? If they ask you, is there any other consistency you know? Rubbery texture is for lymphoma. Something. Will I be able to appreciate in a patient? Maybe not, but rubbery consistency is something which is mentioned for lymphoma. I want you to know that, right? They will definitely ask about microscopy. You have to be at your fingertips. These are places I would say don't think. Answer. Microscopy of tuberculosis, I will have caseous or non-caseous necrotizing lymphadenitis, right? You'll have caseating granulomas which might be coalescing. Coalescing caseating granuloma is a classical finding for your tuberculous lymphadenitis. See, before them asking the next question, where do you see non-caseating lymphadenitis or non-caseating granuloma or non-necrotizing granuloma? I want you to tell upfront. See, granulomas is a very important topic which might steer the discussion in any pathway, right? Here I see coalescing caseous granulomas with or without giant cells. Perigranuloma, you will have lymphocytic infiltration without fail. The closest thing which comes in your mind is sarcoidosis, right? Tell them over them also, right? I will see non-caseating or non-necrotizing granuloma in sarcoid, in foreign body, in Crohn's disease and many other chronic inflammatory conditions. Enough? That's more than enough, right? The moment you say the term giant cell, the question will automatically jump to what is the type of giant cell? Is there any name? Or how do I identify? How do you tell it's a Langhans type of giant cell? Langhans is important. First thing, don't fumble between Langhans and Langerhans. Langerhans is a dendritic cell, macrophage, and Langhans is a giant cell seen in tuberculosis. Before telling about Langhans giant cell, I want you to start the question by saying giant cells are generally named based on the arrangement of the nucleus. based on the shape in which nucleus are arranged. If the nucleus is arranged in the form of an arc or a horseshoe or a U-shaped arrangement, the multiple nuclei in the giant cell, we name it a Langhans type of giant cell, which is more seen in tuberculosis. Also add that there's something which is not specific only for tuberculosis, it's a finding seen in tuberculosis, that's all. It's very, very important for you to add that, right? Same time, I can have giant cells having a circular or a wreath-like arrangement. We call them a two-tone giant cell, which is seen in case of a xanthoma xanthelismas. Facade arrangement, you see in case of a foreign body giant cell. Add on to them when they ask about Langhans giant cell, right? Perfect. Then if they say that, how do you investigate Mycobacterium tuberculosis? Is biopsy enough for me to say it's tuberculosis? Answer is no. It is not enough. K-shading granuloma is suggestive of tuberculosis, not diagnostic of tuberculosis. I need to demonstrate the organism. Unless and until I demonstrate the organism, my diagnosis is not sorted, right? How do you demonstrate? Simple Zeal-Needson's technique. You can do it on a biopsy also. Like a sputum smear, I can do it here. I have to demonstrate there. But the best way to demonstrate without any fail is TB-NAT, right? PCR-based nuclear acid hybridization structure, right? Culture is some things which is not routinely done these days. If you know the answer, if you're strong in microbiology, add on that. Yes, you can use an LG medium to culture as well. But TB-NAT has to be there. And microscopic demonstration of your AFB positive structure is something which is very, very important for me to identify and confirm it is a Mycobacterium tuberculosis. The advantage of TB-NAT is you add on to it. Along with the diagnosis, the TB-NAT will also say whether this specimen, this bacteria has resistance for rifampicin isoniazid or not, so that I'll be able to manage or plan the treatment protocol as well, right? Perfect, right? Next, differential diagnosis of granulomatous condition. Like I said, there are multiple things. Start with TB, leprosy will have granulomas. Your sarcoidosis, like I said, fungal infection will have granuloma, atypical mycobacterium will have granuloma, few special granulomas, don't forget them, right? These are meant for Viva, right? Cat scratch disease will have granuloma, which is stellate or a Charles tape. It's an irregular granuloma, right? You have your donut shaped granulomas. In Q fever, you can have them in allopurinol toxicity. You have your microgranulomas. They are very tiny granulomas without giant cells in case of toxoplasma lymphadenitis, right? Perfect. Those are few questions which can come in a TB specimen. But trust me, tuberculosis is something which is very difficult to handle because the discussion can go in any which way whatsoever, right? Perfect. The third thing, I have taken a fresh specimen for the discussion. It's a gastric adenocarcinoma. Generally, most of the hospitals will have mounted specimen, but there is a very likely chance that you will have fresh specimens also. Fresh specimens are a bit difficult to explain, especially for an undergraduate. For a postgraduate, it's very, very easy to explain, right? So a fresh specimen, first and the foremost thing, ask a glove and hold it. You hold the specimen, first put in the anatomical position, right? That's very easy and important to do it. The moment it's in anatomical position, you can exactly explain what it is, right? So there's a simple cut open surface of stomach along with attached greater omentum. I am making a fact that there's a greater omentum, pad of fat attached, so it's a stomach, and not just that. When I say greater omentum, I will tell that that's a greater curvature of stomach, right? And the stomach is opened along the lesser curvature, which is opposite to the greater curvature. And once the stomach is open, you can see a huge ulceroproliferative mass. This part is the ulcer. The whitish area is the ulcer, which has the necrotic tissue there. And there's a mass which is proliferating surrounding that. I have a 4 into 5 or 6 into 7 centimeter fresh specimen. If you have a scale, measure and tell, which is so much centimeter from the proximal, so much centimeter from the distal margin. Very important to tell. If you are able to put them in anatomical position, tell them with confidence that I am seeing so and so mass in the antral region of stomach, or in the greater curvature, or in the lesser curvature, or in the body or fundus or cardia. The anatomical location and description will definitely elevate the experience and you will get a better mark, right? Perfect. On this part, looking at the size of the ulcer and the heaped up margin. See, the ulcer generally here, this is an ulcer, right? But here how it looks is, it looks like there's something, there's a base, there's something which is growing on top of, right? That's a heaped up margin. It's bulging outside. A heaped up margin of the ulcer, and I don't see any of the trabeculae reaching till the heaped up margin. I will think mostly in terms of a malignant gastric ulcer, and a gastrectomy is done, has to be a gastric adenocarcinoma, right? As simple as that. So what will I look for? I look for an exophytic fungating mass, ulcerative, or a diffuse infiltrating lesion, right? This will steer the conversation into linitis plastica. Please be very careful for that, right? Be ready for them, that's all, right? Mostly it's going to be an ulcerative proliferative mass, fungative mass. At the same time, I can have an ulcerative infiltrative mass where the tumor cells go into the wall of the stomach, no gross lesion, the rugosities look flat. You might not even see an ulcer in this patient. That also can be in your exam case, right? So what are the two major histological subtypes? WHO cares for these two. There might be like 10-15 types of classification of gastric carcinoma, but intestinal type, diffuse type of gastric carcinoma is something which I want you to remember and tell that this is based on WHO. That's it. So what do you see in the diffuse type of gastric carcinoma microscopically? Or in other words, how it's different from intestinal type? Intestinal type has classical glands, malignant glands with invasion. But diffuse subtype will not have malignant glands, right? Intestinal subtype shows malignant glands. But diffuse subtype, the reason is they have Ziegler ring morphology. They are poorly cohesive cells, they are single cells. They have single cells with mucin inside pushing the nucleus to the corner looking like a Ziegler ring. The next question is, why is it like that? Answer is simple. You know the answer, that's due to CDH1 loss. CDH1 mutation or loss of function mutation will result in your loss of E cadherin, which will make sure the cells are dispersed. And because of the dispersed lesion, you will have marked desmoplastic reaction because the tumor cells go into the layers of the stomach. And because of the very thick, rigid, non-expansile like a leather bottle, so we call it a leather bottle stomach or a linitis plastica. Everything required from the gross of gastric adenocarcinoma is sorted, right? Next is few important manifestation. They may not ask you like this, name some metastatic manifestation. They may not ask you like that. The question will be, what is Voce's node? You should be able to answer that. It's a left supraclavicular node seen in case of a gastric adenocarcinoma. Very important. I should be able to explain that. What's a Krukenberg's tumor? It's a gastric adenocarcinoma, especially the diffuse type. Because of the loss of E cadherin, they're able to go into the ovary and get deposited there. Systematic dose of nodule. It's an umbilical metastasis, or I can have peritoneal deposit, right? All these can be one-liner Viva, which can come in an exam if you have a gastric adenocarcinoma specimen. Done, sorted. Next, go to the next guy. Simple guy. Like I said, simple might be difficult, right? So if it's a old specimen or a fresh specimen, it's a jar mounted specimen of a lung. If you're able to say left or right, say confidently, otherwise ignore. No one cares. Cut bivalve specimen of lung, where you can see the inner bronchus, the hilum, where you can see the vessels in the bronchus, and here in the upper lobe of the lung, close to the pleura. See, like I said, it's about imagination here, right? Close to the pleura, I see a fibrocavity lesion. The first question is, how do you say fibrocavity? You can see an empty space. That's by default a cavity. Why fibrosis? I see a whitish area around, right? That's definitely fibrosis. By default, when there is cavity, you will have fibrosis. So I see a fibrocavity lesion measuring so and so centimeter. Close to it, I see multiple tiny nodules which are whitish in color, which could probably be lung lesions or could be the draining lymphatics in the lymph node, which also has the caseous change. Because of the fibrocavity lesion and the whitish discoloration looking like caseous change and lung specimen, I think of a pulmonary tuberculosis. If you're specific, I want you to say secondary pulmonary tuberculosis, because primary pulmonary tuberculosis does not have cavity. Cavity is a form of secondary pulmonary tuberculosis only, right? Perfect, done. So how do you identify? It's simple. Lung showing irregular cavities, thickened fibrotic bands in the upper lobe, most likely secondary pulmonary tuberculosis, right? Okay. Next question is, why does secondary pulmonary tuberculosis predominantly involve the apex? See, because primary pulmonary tuberculosis has a place. You must have read about the Gons complex, Gons focus, right? The upper part of the lower lobe and the lower part of the upper lobe. That's where the aerodynamics leads them. Why secondary the apex? Simple. TB mycobacterium is an obligate aerobe. They want the oxygen. There's a high oxygen tension in the apex of the lung. That's the reason it has more predilection towards the apex. I am not saying it's not seen other places. It's more commonly seen in the apex because of the high oxygen tension present there, right? How is tuberculous cavity formed? Tell the entire pathogens of granuloma. Because of such an intense amount of inflammation, in order to kill the TB bacilli, which is very difficult to kill, my body automatically destroys my host tissue also. So you'll have a secondary destruction and a subsequent formation of cavity. Whenever there's a cavity, it will heal. Healing is always by fibrosis. That's why I have a secondary fibrocavity lesion. Fine. What do you see in the microscopy? I'll see the same thing. Microscopy will have the same thing. In the wall of the cavity, you'll see the same Langhans chain cells, same caseating necrotizing granulomas, coalescing granulomas. There's no difference between this and the TB lymph node. I'll see the same same finding, right? What could be the complications? It's very important. Here is where it goes clinical a little bit. Yes, I can have hemoptysis because granuloma, the cavity might have vessels in the corner which can erode and can have hemoptysis, or per se destruction of the tissue can result in hemoptysis, right? Okay, you can have spread from one place to other. You can involve the pleura because it's a bit close to the pleura. It can go here and cause pleural effusion or pneumonias of that sort, right? Definitely. Excess fibrosis per se can affect the lung function. Secondary infection, very, very important, especially aspergillus. See, aspergillus is a lazy organism. They don't go and infect the lung on its own. I have a cavity, it's already laid up for me. It goes there, invades there, and can cause a fungal ball or an aspergilloma. There's a very common complication of a secondary cavity of a tuberculosis. And like we started with hemoptysis, it will automatically lead to a named finding, a finding called an Rasmussen's aneurysm. Okay, so here within the tuberous, it's a cavity, right? I can have in the wall of the cavity a bit of a pseudoaneurysm because of destruction. I can have an aneurysmal dilatation of vessel where it can bleed and it can have hemorrhage into the cavity, which also can result in hemoptysis, right? Perfect. I'm zooming out. That's about the lung sample of a pulmonary tuberculosis, right? Please be ready to explain what is primary, what is secondary, what is miliary even, right? This is dissemination into the blood circulation throughout the body where you can have tiny millet seed-like deposit in your lung, in your liver, in your spleen and any such organ, fine? Perfect. Last specimen of today. It's a squamous cell carcinoma of foot. How do I start the discussion? Simple. It's an amputation specimen of left or right foot. You have to identify based on the thumb and the great toe and the orientation, right? Perfect. In the heel, close to the heel, I have a 5 to 6 centimeter lesion. Here, please trust me, I don't want the distance from here because beyond heel there's nothing. Neither I want distance from here. I want distance from the cut stump. I don't see them here. It's a 3-dimension, right? You'll have something which is cut like this. The foot will be cut in the leg. I want the distance there. It is 4 centimeter, 5 centimeter from the distal cut margin of the amputation specimen. That's important. And here I have 5 into 5 centimeter lesion and it's cut here. So I can say the third dimension also. And it looks like it's invading close to 1.5 centimeter into the foot, but I need to measure to say the exact infiltrating part. You can be open about that, right? And the lesion grossly is pearly white in nature. It's fungating a cauliflower-like growth, something which all of the examiners want to hear, right? A cauliflower-like, a pearly white lesion, fungating mass in a skin-attached condition is most likely a squamous cell carcinoma. That's all, right? We always look for few things, right? Grossly, ulceroproliferative, fungative mass, necrosis, yes or not, present or not, you can say. The cauliflower-like growth, the pearly white lesion are something which we always look for in an exam, right? In a Viva, we look for them. Basic things we look for them, right? Okay. What are the important predisposing factors? Squamous cell carcinoma can have multiple factors. Don't forget a few things. Any chronic scar, don't forget. And UV rays. Without fail, UV rays should be there. Any chronic inflammation, could be burns, could be sinus, could be immunosuppression, anything. You can have a chronic osteomyelitis related sinus, possible. Recurrent, any chronic irritation to the skin or UV ray is one of the reasons for your squamous cell carcinoma of skin. The moment you say burns, they'll automatically jump and ask you, then what is Marjolin's ulcer? Marjolin ulcer is a ulcer which comes on chronic scars. Could be a burn related scar decades back that keeps on irritating slowly and slowly. It can develop into a squamous cell carcinoma. That's one of the important named lesion. I want you to know that, fine? Okay. So what do you see in microscopy? Never forget keratin pearl. We know that, right? We know the patterns. Keratin pearl, features of dysplasia, invasion. Keratin pearl is a finding of well differentiated. So what are the other differentiation, right? See, if they ask you about the differentiation and the aggressive behavior, there is a way to classify squamous cell carcinoma based on the percentage of keratin pearl. I cannot generalize it for every squamous, mostly, right? We call them Broders classification, not recently used for reporting, but it still exists, right? More than 75% keratin pearl, very well differentiated, less than 25, poorly differentiated, and in between, moderately differentiated, right? Called Broders classification based on the keratin pearl environment, right? Perfect. And how do they spread? It will almost always spread through lymphatics. So if you have a squamous cell carcinoma on the foot, it's must for you to examine the inguinal lymph node to see whether the lesion is spread or not, if there's a lymphadenopathy present or not, right? Prognostic features, again, differentiation. This will never go out of fashion. TNM, grading, that's all. You can name it the way you want. Here I'm saying, poor differentiation is poor, grading. That's all. Nodal involvement is poor, TNM. Bigger the tumor is poor, TNM. Distant metastasis is poor, TNM. Lymphovascular is poor, TNM, right? That's all. TNM and grading is the important prognostic feature apart from that molecular. Luckily, squamous cell carcinoma of the skin does not have much inputs about molecular classification and about the molecular prognosis, so we can ignore that, right? Perfect. So that's with respect to this lesion, this class. I'll put the footnotes in the app and also I'll share it to you in the WhatsApp. Have a look at them. Keep reading them, keep answering them, ask your friends your questions so that you are more comfortable in answering the questions. Knowing alone is not enough for a Viva, right? See you soon in the next video. Till then, bye-bye from Dr. Ranjith. Bye-bye.